Thank you very much, Dr. Prapan. I feel I've been called out a little bit. I'm not going to attempt to prove my Mandarin fluency now on stage. I feel like that would end badly for me. I was asked to give a presentation on technology-based interventions and how they can be used to improve the HIV cascade for prevention, care, and treatment. This is going to be a bit of a different presentation than the ones we've had so far this morning. It is not a medical presentation. I would argue it is still a technical presentation. But it's also going to be different because integrating information and communication technologies into the HIV cascade is a massive topic, and if I wanted to talk about all of the different models and all of the different ways this could be done, that would be extremely difficult, and I don't want to do something that's extremely difficult. So instead, what I'm going to do is present sort of a global strategic framework on the integration of ICT into an HIV cascade program. And then I'm going to share some innovative models that my program, LINKAGES, has been piloting in various countries around the world, and especially in this region. You'll note the slide says that this is a crowdsourced presentation, and that's because I'm really standing on the shoulders of very smart people who work for my organization, FHI 360, and have been developing these pilot models. So I'm really stealing their work and experience to present today. And at the end of the presentation, I'm going to share their names so that you can pester them with follow-up questions about these models. So, using the expression HIV cascade, and I want to make sure that that's an expression that people understand. The idea of an HIV cascade is that if we're going to achieve 90-90-90 goals for controlling and reversing the HIV epidemic, we're going to need to stop looking at intervention programming in terms of targeting a single silo. For instance, only targeting prevention, or only working with testing, or only focusing on treatment. We're going to have to find new ways to link those services together into a single continuum, and to make sure that, that our clients, and particularly members of high-risk key populations, are being brought into that continuum and retained across the continuum. So not just receiving prevention, but receiving prevention and being tested. And not just being tested, but receiving ongoing support, whether one tests HIV positive and needs to start ART in a timely manner, or tests HIV negative and needs to be retained in prevention programming, which could include support for ongoing use of condoms, access to clinical interventions like PrEP, as well as ongoing repeat HIV testing. So this is what I mean by taking an HIV cascade approach. And taking a cascade approach, linking those different services together, and not just linking them together, but having access to the data that is necessary from multiple systems and multiple providers across that cascade, is an extraordinarily complex task. And fortunately, information and communications technology offers us new opportunities and new models for how we can link those services together and how we can track and evaluate their performance over time. So there's really been, in the last several years, sort of an explosion in the scientific literature around how you can use ICT to do this type of programming better. I know this because we just recently completed a systematic review of publications in the last 2 years that were related to ICT within HIV programming. And we found 29 separate publications for 29 separate studies that looked at ICT and HIV. And those were only the publications that focused on the use of real-time data. So the actual number of publications just in the last 2 years is going to be much larger than that. And when we looked at those studies, we found a couple of things. And to me, what's most important is we found that published studies on uses of ICT tended to focus on one particular stage in the cascade. So they might be looking at how you use ICT to better reach members of a target population, or they might be looking at how you use technology to improve uptake of HIV testing and to get better case finding rates with that testing. Or they might be looking at how you use technology to increase adherence to ART. But what we found were there were very few studies that looked at the overarching framework of a cascade and how do you implement ICT across that cascade to improve functioning of the continuum as a whole. So to put that slightly differently, what I might say is that there are a lot of programs out there that are looking at the uses of ICT tactically, but not many programs that are looking at the uses of ICT strategically across an entire program. Which brings us to FHI 360's, the FHI 360 linkages project's draft global vision on the strategic integration of ICT across an HIV cascade. And I've highlighted draft there because we talk about things being hot off the press. This is a case of the press has not even been turned on yet. This document is a work in progress. In fact, as I was sitting next to my colleague this morning, I saw him on his computer hurriedly making further revisions to this document. So even what you're seeing now has probably already been changed. But what this is an attempt to look at the cascade and to present a typology of ICT innovations and ICT models that apply to different stages of the cascade, or in some cases apply across the entire cascade. And broadly speaking, what we're looking at is how you use ICT to better identify members of your target population and plan appropriate interventions for those populations. We're looking at models that help us to better reach those populations and link them into services. We're looking at models that help us to better engage with populations once we have had that initial reach and that initial contact with them, and how to better retain them over time and offer the support that they need. And I do think it's very important, I want to make a note here, when we talk about retention and when we talk about support, we're very often talking about support for people who are HIV positive. But what this framework is trying to show is the idea that ongoing engagement and ongoing support is important not only for those who are HIV positive, but those who are HIV negative as well. And last but not least, how we use ICT across the entire cascade to help us assess the delivery of our programs and improve the functioning of those programs over time. So as I just said, some of these innovations are things that really apply to one specific step in the cascade. Some of them apply to multiple steps in the cascade, or in fact across the entire cascade. Now, currently, this model is really set up to emphasize the idea that we're looking at engaging with members of our target populations online in virtual spaces, but shift them into real-life interactions for physical service delivery, into HIV testing clinics, into ART service providers. We do expect over time, as we develop better technologies, as we develop better models for using those technologies, that even some of this clinical service delivery that typically would require a face-to-face real-life interaction, even some of that can increasingly be shifted into online virtual interactions. And as part of that, these sort of clearly delineated categories, as we start to make that shift, some of these categories may also start to overlap over time, and this clear delineation between categories may no longer be so clear. But what I want to do, instead of focusing too much on this strategic vision, because as I said, the strategic vision is still being finalized, still being worked on, is I want to drill down into each of these categories and just show you a few tools and a few models that Linkages has been developing and piloting across each one of these steps. Beginning with using technology to better understand our target populations and to better plan our interventions. So the Linkages project has developed a whole raft of tools, and these are used for a process that we refer to as virtual stock taking and mapping. And the idea here is gathering data to better understand how members of our key populations use information and communications technology, meaning what's the level of internet connectivity, what are the channels, apps, websites, essentially what are the virtual venues that members of these target populations use that we can also target as a means of reaching out to these populations. So to help us identify those what might be called a virtual hotspot, and also to prioritize, recognizing that just as in real life, you may have a map of physical spaces where you can reach your target population, and some of those spaces may be higher risk or higher priority than others. Virtual hotspots are no different. There may be a whole range of virtual venues where you can reach your target population, and part of this stock-taking process is identifying which are going to be the most relevant to my program. Which are the highest risk? Where am I going to be able to reach the largest numbers of people that I need to reach? So mapping these hotspots, prioritizing hotspots, and then creating profiles for the subpopulations that you're going to be reaching at the different hotspots. And this is a process sometimes called social listening, and I'll show you a picture of what that might look like in just a second. But then once one has gathered all of this data, then using the data to plan differentiated outreach and prevention strategies and make sure that for each of the subpopulations you're targeting, in each of the virtual platforms where you're reaching them, that you're offering the information and the messages and the services in the most appropriate ways for the needs of those different target populations. So the whole idea here is it's not intended to be a one-size-fits-all model. It's intended to be differentiated and tailored to the specific needs of the subpopulations. And just what you're seeing in this picture here, this is just one example, the Malawi Sexual Health Assessment, which was a virtual stock-taking exercise that Linkages conducted with MSM in Malawi. That was conducted via a SurveyMonkey form that was sent to people as a link over websites to their cell phones and advertised through social and sexual networking apps so that they could collect more information anonymously on members of this target population and how they used ICT and where they could be reached online. So just as an example of what this might look like. Now, I said I was going to talk a bit more about the social listening, and the idea of social listening for people who aren't familiar with that is when you've identified these virtual spaces, whether it be a chat room or a message board or a Facebook group, is going to these spaces and spending time not talking, not educating, but listening and understanding better who are the people who I can reach in this space and what are the things that are interesting to them. What are the topics they're interested in? Who are the people that they follow online? How can I best initiate a conversation with them? And critically, a lot of this social listening is not at all about health and not at all about HIV, but it's about what are the other topics of interest to members of this target population. So this is, these are the outcomes of a social listening exercise that was done among MSM in India. And as you know, none of these people were talking about HIV. None of them were talking about testing or even health generally. They were interested in specific social media influencers or singers or actors. And this type of information helps us better plan how we're going to reach them and how we're going to engage with them once we reach them. I'm going to come back to this just a bit later in the presentation. But first, I want to talk about once we have conducted these stock takings, once we have mapped and prioritized specific virtual venues where we're going to reach members of our target populations, how do we then go about reaching them? And as part of this strategic process of planning a global framework for ICT, one of the things Linkages has done is tried to come up with a typology of outreach strategies to be more clear about what we mean by outreach. And so what we've done is divided it into three different broad types of outreach. Outreach 1.0, which is what you might think of as the sort of traditional, in real life, venue-based peer-to-peer outreach, where you have volunteers or peer educators or outreach workers going into the community, meeting people, talking with them, offering them education and referral. And then we have Outreach 2.0, which is becoming increasingly popular, where you take that kind of one-on-one or one-on-few interaction, and instead of having it face-to-face in a physical venue, you're having it in a virtual venue online. So now, instead of the outreach worker going to a gay club or going to a park, the outreach worker is logging on to Grindr or going into a chat room and having conversations directly with members of the target population over those channels. And the benefit here is the potential to reach people that increasingly we might not be able to reach in physical spaces in the real world, because as these venues, these virtual venues become more predominant, our target audiences are shifting from the physical to the virtual. So that's the benefit of Outreach 2.0. Perhaps the challenge of Outreach 2.0 is that it's still quite human resource intensive. It still needs a person sitting in front of a computer or on their phone, finding people one-on-one and having a conversation with them. So it's resource intensive and it's a time-consuming process. So increasingly, what we're looking at is what we call Outreach 3.0. And the idea of Outreach 3.0 is, as our technologies improve and our ability to use those technologies improve, and particularly as we have better data on the online habits and preferences and interests of our target populations, we don't need to reach them online. We can develop and provide tools to allow members of our target populations to reach themselves online. So we don't necessarily need an outreach worker paid to sit in front of a computer and chat with people. If we know how to target correctly, and if we know how to develop our content correctly, we can provide online resources that members of our target populations can directly access themselves to get the information they need to generate the referrals that are the right referrals for them. And again, as our technology gets better, through these online key population controlled technologies, we can actually simulate a human-to-human interaction without the need for the actual human being there mediating that interaction. So just to show you a bit of what that might look like, this is a model that we are currently trialing in Thailand with MSM and trans women here. The idea was to identify key online influencers within these target populations who have access to sometimes very large and sometimes very high-risk groups of MSM or trans women in online and social media venues that we don't have access to, where we can't reach these individuals, but these social influencers can. And instead of having our outreach workers go into these venues and try to reach people and talk to them about HIV, engaging with these key influencers, asking them to spread information about HIV, about testing, about PrEP, to amplify the content that we generate and share that with their members, and to help us link their members into service delivery like HIV testing where people are interested in that. So what you can see here, these are screenshots of what some of these venues might look like. Over here on the right, this is a screenshot of closed Facebook groups in Thailand that are frequented by men who have sex with men who may or may not be gay identified, but where they interact with other members of the community in these closed online groups, sometimes in quite large groups. This very first example there, this is a closed Facebook group with almost 15,000 members who are men who have sex with men here in Thailand and in Bangkok specifically. Some of these groups are organized geographically. Some of them are organized around specific interests. I mean, imagine, for instance, a closed Facebook group with 10,000 men who are all interested in sex. I would think that would be a pretty high priority population for an HIV prevention program, but we don't necessarily have access to this group. The moderator of the Facebook group has access to the group. So part of our stock taking process is identifying who are these key influencers and then working with those key influencers so that they reach the target audience instead of us reaching the target audience. Another version of this, which would potentially have even larger coverage with less human resources, is the idea of targeted social media advertisement. And what you're seeing here is the Facebook Ad Manager. This is for people who are unfamiliar with Facebook. Facebook ads essentially mean when you generate content on Facebook and pay for that content to be promoted to specific Facebook users. And you can, in this day and age, get your Facebook content in front of far, far, far more people if you pay for that content to be promoted. The question is, how do you know that you're paying for it to be promoted to the right people? How do you know that if you're spending $1,000 to make sure that X number of people see your Facebook ad, how do you know that the people who see your Facebook ad are actually members of your target population? This is where the social listening that I mentioned before comes back into play. Because if you've done your stock taking and you understand what are the topics of interest and who are the key influencers for my specific target population, that is information that you can use to better target these ads and make sure that not only are you reaching more people, but you're reaching specifically the people that you wanted to reach. And when you're paying for engagement, you're paying for engagement with the right people. Of course, the question is, how do we know that all of this works? If we're asking social media influencers to reach our target populations for us, if we're paying for boosted Facebook ads to put information in front of users' eyes, how do we know that any of that is translating into people actually accessing services? So here in Thailand, we are piloting a model, we call it O2O, online to offline. We have created an online platform. It's nominally called Res99. This is an online HIV testing appointments platform. And the way it works is no matter how you are brought into the system, whether you are reached by a Facebook post or you see an online video or you see a Grindr advertisement, or an online outreach worker speaks with you. Regardless of how you're brought into the program, you can be sent to this online appointments platform. You pick a clinic, you pick a day, you pick a time. It makes an appointment for you for when you should go in to the HIV test. Now, critically, this online platform is linked to a clinic management platform at each of these clinics. So people make an appointment online, they reach themselves, Outreach 3.0, and when they arrive at the clinic is able to indicate to the system whether or not that person actually came in for their HIV test. This is how we're able to evaluate over time these various Outreach 2.0 and 3.0 strategies for reaching people virtually. Do they translate into people actually accessing physical services in the real world? This is how we can track this. Critically, we're not only tracking whether or not people show up for a test, we're tracking what is the result, what's the outcome of that test. So we're not only trying to identify which strategies and which platforms are best at reaching these individuals and bringing them into testing, we're tracking which of these approaches is helping us generate the highest level of case finding. This is very preliminary data. These are outcomes from about a 6-month period, primarily here in Bangkok. What we found, we had about 1,100 HIV testing appointments made. 62% of those appointments were followed through. The person actually showed up at the testing center. That may sound a little bit disappointing. 1/3 of people who made an appointment did not come in. But compared to physical outreach in the real world, when we look at our real-life outreach programs, clients who are reached by an outreach worker agree to be referred to an HIV test and have a referral generated for that HIV test, only about 27% of them actually show up for the test, compared to 62% when people made an appointment for themselves over this online booking engine. When we look at the different models, what we've been able to see is that our online social influencer and our advertising models reach a lot more people than our traditional online outreach models, but fewer of the people who make appointments actually show up for those appointments. When people are reached online by a paid outreach worker and they make an appointment, they're more likely to follow through with that appointment. And the takeaway from that would seem to be, hey, it's worth the investment in these online outreach workers because they're generating a higher percentage of HIV testing when they actually reach someone. But I want to share a couple more numbers with you. The clients reached by an online outreach worker who tested, 2.2% of them tested HIV positive. So this is a relatively low risk population that the online outreach workers are reaching, compared to the social influencers where the testing yield was 9.3%, compared to the online targeted Facebook, Grindr, Hornet promotions where the testing yield was 13.2%. Which preliminarily tells us something about the volume of people we're reaching via these various channels, but also the relative risks of the target populations that we're engaging via these various channels. Again, as I said, this is all very preliminary, and we're going to be tracking this over time to see if these trends continue. Okay. I talked about understanding your target population and planning your outreach. I talked about how ICT can be used with this outreach 1.0, 2.0, 3.0 typology to better reach members of target populations. There's a hanging question, which is once you've reached people, once you've engaged them in services, how do you keep them in services? And as you'll recall, at the beginning I said we did a literature review on publications in the last 2 years, and what we found was this was actually one of the largest areas of research interest, was in the application of ICT to ART treatment and retention for clients who are HIV positive. So there's a lot of publication out there about this. It tends to focus on two things. It tends to focus on either job aids for clinicians, or automated ART adherence reminders for people who are on treatment and, for instance, receiving a daily text message telling them to take their pills. So there's a lot of publication on that. So I wanted to talk about a slightly different model, which is in keeping with this theme of Outreach 3.0, the idea that members of our target populations can not only use technology to reach themselves, but to help one another be retained in services. So these are pictures of a platform called 57 Zone. This was actually not an HIV intervention. This was a tuberculosis intervention supported by FHI 360 in China. This was an intervention for MDR, multiply drug-resistant tuberculosis patients. And the goal of the program was to get more MDR TB patients on treatment and keep them on treatment. And the idea for this platform actually came from a patient himself. Many MDR TB patients, they tend to be migrant workers. They tend to be quite isolated from their families and from their home communities. And there was a TB patient who said, you know, I'm struggling with my treatment. I'm having a lot of problems. I wish there were a way I could talk to people about this. I wish there were like a website where I could go. So FHI 360 supported him to create this 57 Zone, which is an online platform for tuberculosis patients that is managed by the TB patients themselves. So the people who are running this on a day-to-day basis are not clinicians. They're expert patients who are provided daily oversight by healthcare staff, but most of the interaction is patients with patients. They're providing basic tuberculosis education, online counseling and support, and a very critical part of this platform is where we have TB patients who need to have, for instance, a weekly check-in, but don't necessarily need to go to a physical clinic every week to talk to a doctor because they're relatively stable on treatment. This platform is being used to support telemedicine, where a client can log on to 57 Zone and have a video chat weekly with their doctor just to check in and talk about what's going on, which saves their time because they don't have to go to the clinic, reduces dropout rates, and reduces the burden on clinics and clinicians who can now very quickly log on and chat with a client as opposed to having to have lots of people coming into their clinic. So this model has been hugely popular, hugely successful within the MDR-TB program in China. We're now working with the Thai Red Cross AIDS Research Center to develop a similar model for HIV patients, potentially both HIV-positive ART clients and HIV-negative PrEP clients here in Thailand. Okay, the last model I'm going to share, because I'm cognizant I'm almost out of time, is in our typology, the last sort of set were uses of ICT to track HIV cascade performance and improve over time. So the model we are piloting is as a platform we call eCascade, which is a real-time data collection app that lives on a smartphone. Within our program, each outreach worker has access to this app. Each HIV testing center has access to this app, and each care and support center supporting clients who are on ART has access to this app. The application helps us to track individual clients by unique ID code across all of the stages of the cascade, so we can see where people are being retained and where they are falling out of the cascade. It functions as a job aid. So for instance, it helps our outreach workers to follow a specific SOP when they are interacting with people in the field and make sure that individual clients receive the messages and information they need based on their specific risks. And it provides real-time data so that we can adjust our interventions based on what's working, what's not working, where people are falling out of the cascade. I do want to note what you're seeing in this picture here is not just that we're using eCascade to link data from outreach to testing to treatment and support, but we're also, at each one of those steps, we are linking our data to the Thai Ministry of Public Health's national data collection systems for outreach, for testing, and for treatment. That means that this system is not only collecting data to help us better understand our programs, it's collecting data to help demonstrate the value added of these community-based programs to the national HIV response, because it's feeding data into the national data collection systems. That makes it sound like this system is primarily interested in monitoring and evaluation. That's not true. I would argue the key advantage of this system is it enables adaptive program management on the part of our implementing partners. So we've created an online dashboard called eCascade View where where our implementing partners can go online any day, review their cascade. How many people are they reaching? How many tested? How many on treatment? They can break down the cascade in various ways to help them better understand who they're reaching and how they're serving them. They can characterize their target population by demographic data. How old are the clients we're reaching? What target populations are they? They can characterize their clients by their self-reported risks. So we can look at, are the people that we're reaching relatively high risk or relatively low risk, and why? And we can also track workflow over time. So because all of this data is being entered by implementing partners in the field, so we can track how many of our staff are being active. And where is staff not being active and why. So it's also a workforce management tool. So every time I present eCascade, I just really want to stress that message that it's not primarily about monitoring and evaluation. It's primarily about how you use that data and how implementing partners use that data after it's collected to make programmatic improvements in real time, as opposed to waiting until the end of a project and then finding out what worked and what didn't work. I realize I'm just about out of time, but Dr. Prapan hasn't stopped me yet. So I have two very quick slides. As we have developed these innovations in multiple countries for multiple populations over time, we've come up with some key common challenges that we face everywhere we try to integrate ICT into programs. The first is the issue of ownership of these solutions. And the idea that it is incredibly difficult to introduce these innovations if they're viewed as primarily serving the interest of an external donor, as opposed to serving the interest of the implementing partner or the target population itself. It is important that these innovations be viewed as additive, that they add value to existing systems, as opposed to duplicating existing systems, or even worse, being destructive of the existing successful work that implementing partners are doing. So it has to improve things, it can't make it worse. There are ongoing concerns about privacy, which is a real challenge anywhere you introduce ICT. This allows us access to a vast universe of data that we did not necessarily have before, and that raises questions about how we collect and use this data while maintaining the privacy and confidentiality of our client populations. And it's incredibly easy to underestimate the resources and the time that is necessary, not only to plan and launch these interventions, but to sustain them over time. Given those challenges, I'm almost done, I promise. Just a few key recommendations. First, that whatever ICT implementation you're planning requires significant pre-planning, and the most important part of that pre-planning is early and frequent engagement with your end user. To better understand what are their needs, how are they currently working, how will your innovation fit into their existing workflow, and if it's going to disrupt it in a positive way as opposed to in a negative way. As you're rolling out these innovations, what we found is an incremental step-by-step approach. Small changes over time tends to be better accepted than sort of the big bang approach of we're going to introduce a lot of huge changes at once. That makes people very resistant to change. And referring back to the review that we did earlier, There's a lot of publication on ICT and HIV. There are relatively few rigorous evaluations of how well all of this works. At the moment, the state of the literature is really in a place of describing more than evaluating. And I think because of that, it's very important for any program planner who's seeking to implement ICT solutions, there's a real need to manage unrealistic expectation, to not overpromise as you're rolling out these innovations with implementing partners or to national governments, but to make sure people are very clear on where this can add value, but also what are the limitations. And as part of that, making sure that everyone involved understands ICT is not a panacea. ICT is very exciting. It can help us do a lot of things that we were not able to do before. It does not solve all implementation problems, and it brings its own set of challenges when you seek to implement these innovative models. I think it's very important to communicate clearly to partners when you're planning and implementing these solutions. All right, I'm done. The last thing I wanted to do was, as I promised, this is not my work. This is standing on the shoulders of giants. These are the names and contact information for a lot of the FHI staff members who were instrumental in designing and launching the pilot models that I shared today. I would encourage anyone who wants more information on any of these to reach out directly to these individuals. They would be happy to talk with you about how we've done this, how it's working, what are our next steps. Thank you very much.